The third speaker is Dr. Susirith Mendis, Professor of Physiology in the University of Ruhuna and currently second term Vice Chancellor of the University of Ruhuna. He was my student a couple of decades ago, and now I regard him as my teacher in the subject of ethics. I have not met anyone who speaks on ethics so eloquently, so clearly, so brilliantly as Professor Susirith Mendis. Professor Susirith Mendis, you start at 9:41.
Thank you, sir. Professor Carla Fonseca and distinguished members of the head table, ladies and gentlemen. I'm indeed privileged to speak on the subject of medical ethics at a session chaired by my revered teacher, who has been, in my younger days, my role model and idol. And perhaps I chose an academic career in physiology because of his influence. Today I have been given the task of speaking in 15 minutes, less or more a few seconds, on the topic of medical ethics. Obviously, those of you who know about it would clearly realize that that's almost an impossible task. So I'm also aware that if you are a good teacher, you can speak on any subject in any given period of time. So I'm trying to ensure that I'm known and accepted as a good teacher, which means that I will try and keep to my 15 minutes. Which also means that I have to select and ensure that I only touch upon some areas in medical ethics. And what I have chosen to do is take two areas which are commonly talked about: the doctor-patient relationship and patient autonomy and informed consent, and two areas that don't get much talked about, and that is ethics of institutional medicine and truthfulness. Let me begin this short presentation with three quotations, two from antiquity and one from modern times. Hippocrates said, as to disease, make a habit of two things: to help or at least do no harm. 600 years later, the Roman physician, who Wikipedia says is arguably the most accomplished researcher of antiquity, Galen of Pergamon, put this more succinctly and simply by the Latin phrase primum non nocere, meaning first, do no harm. And that has been a foundation of medical ethics. Do good if you can, but make sure first that you do no harm. The third is, again, arguably the most famous living medical ethicist, Edmund Pellegrino. I had the good fortune to spend 4 weeks with him at Georgetown University in 1997 while on a WHO fellowship. And this particular quotation I do keep quoting at each of my lectures in medical ethics. He says, what is at stake is a fundamental recasting of the traditional image of physicians, one with profound implications for their social situation as well as their image of themselves. The need for this recasting is implicit in the disquietude expressed by many patients who call for a more humanistic profession. Medical ethics is broadly defined into two categories. First is normative or rule ethics, which talks about medical negligence, malpractice and professional conduct, abuse of doctor privileges, medical confidentiality, association with unqualified persons, advertising, and improper conduct within a professional relationship. But I have always tried to focus my attention on medical ethics on the other category, which is meta-ethics, where one argues and discusses issues which are conceptual, moral judgments, and values in medicine. It is a place where you discuss and express points of view on a broad framework for the discussion of moral and philosophical issues in the principles and practice of medicine. It is a place where we talk about a debate on the art versus craft in the delivery of healthcare, and also the theory of moral justification and evaluation as applied to medicine. Historically, the relationship between the physician and the patient has been dominated by the doctor's point of view. Traditionally, medical ethics was derived from the physician-centered point of view of what they are and what they ought to do for their patients. These physician obligations, which were based on a professional ethos that had developed through the exalted image of the physician in society, had several reasons for it to have served reasonably well in the past. They have, for quite some time, been in need of serious reappraisal. And the concept of medical ethics are fast changing within the medical profession as well as within the consumers of medical care, that is, the patients. Medical decisions and quality of care are increasingly becoming issues of public concern. Varied reactions to them are appearing in medical, medico-legal, non-medical literature as well as the public media. The conduct of medical professionals is receiving increasing attention and often criticism in the national press. In this context, it is pertinent to quote Dr. A.J. Dyke, who writes this in the New England Journal of Medicine many years ago. The distinctive mark of a profession and a source of the confidence it engenders is its ability and willingness to specify and justify standards by which its conduct can be judged by its members as well as society. Therefore, the distinctive quality of the almost sacred doctor-patient relationship must rest on a solid foundation of mutual trust, equality, and respect. If I get on to the issues of patient autonomy, patient integrity, and informed consent, the principle of autonomy of the patient lies in the inherent quality in all rational beings that enable them to make reasoned choices, which in clinical terms means respect for the patient, his intellect, his individuality, and his values. The principle was legally affirmed nearly 100 years ago by the famous judgment of U.S. Justice Cardoza in 1914. He said in his judgment on a case that came to him in 1914 that every human being of adult years and sound mind had a right to determine what shall be done with his own body. And a surgeon, which was the case that he came to him, who performs an operation without his patient's consent, commits an assault for which he is liable in damages. Well, we have come a long way since then. And informed consent is now a well-accepted principle in medical ethics and followed more often than not in certain situations to the letter. But we also find in the Sri Lankan context situations where it is in abeyance. The doctrine of informed consent is based on the concept of autonomy of the patient. It rests on two standards. One is the materiality standard, where what a patient would consider material and meaningful to his decision-making process is considered. And secondly, the medical practice standard, which is the standard set by the community as to the accepted extent of its disclosure. Therefore, the two standards though in consonance with each other, there are times that they can be mutually exclusive and can lead to ethical dilemmas. But the current legal trend is that the role of physician should be as counsel to the patient and not as decision maker. Therefore, it is important for the doctors to create conducive conditions for informed consent. This is particularly important as modern medical practice is by its very nature an interventionist one. And in principle, all medical interventions need the informed consent of patients to be ethically acceptable. The roots of informed consent lie in the concept of autonomy. Medical practice without meaningful informed consent indicates disrespect for the patient, a violation of his autonomy, and defeats the very ethos of the practice of medicine.